Thank you for the invitation and the title. It's a different title than I normally speak of, but it was a good challenge though. So I'm not a clinician and do primarily do research. And so I actually have to be in contact with my clinical colleagues and the persons who deliver lifestyle interventions also in order to make my own research more clinically relevant. And when I got this title, I got to think about a conversation I had with a physiotherapist a while back, and let's see if I can shift my screen here. There we go. So the physiotherapist asked me how do I boost my patients using exercise, and that boost question is well, what do we mean about that? So the physiotherapist, well, how do you get them to get better? And in order to kind of reflect about what exercise does and how it does it and it can be used as a treatment, this is a really relevant question actually. So what is meant by better? And also and what it then goes back to what we want to treat here. And I need to think about that when doing research with exercise, especially when we're talking about treatment of diabetes. So for the non-clinicians among you, and that it's important to know that the end objective here is maybe to reduce the excess mortality in type 2 diabetes and reduce the macro and microvascular complications associated with the disease. And in order to understand how exercise actually does that, we also need to know about how we treat the disease in the clinic. And to get to that point, we also need to understand the disease. So type 2 diabetes is really complex. It affects all organs, and I'm going to briefly take you through the pathophysiology here, and there's more to it than that. So, but insulin resistance is the main driver of type 2 diabetes, and both the muscle, liver, and adipose tissue. That affects the pancreatic beta cell that will get exhausted over time, and that results in hyperglycemia, among other things. But also it has a range of effects that would increase low-grade inflammation, but you will not only see hyperglycemia, but also hyperlipidemia and blood pressure as a result of the pathophysiological process here. So why is that important? Because that's some the knowledge the clinicians need to know when they treat the patient. So in Denmark, at least, the family physician is the key stakeholder here who will treat most type 2 diabetes patients here based on partly their symptoms on complications and the complications. So to do that, they increase the intensity of pharmacotherapy here, and to help them guide that, they often, at least in younger and newly diagnosed type 2 diabetic patients, use a treat to target approach, meaning that it will increase pharmacotherapy to get their metabolic values down to a certain target, for instance, cholesterol, blood pressure, and HbA1c, which is the mean blood glucose. So this is what I have to deal with, something I have to take into considerations when thinking about how exercise can be used as a treatment. We need to see an effect on the treatment targets, and we need to be able to at least understand if they can decrease the complications associated with type 2 diabetes. So before going any further here, I just want to reflect on physical activity and exercise, because they're not entirely the same and they're used interchangeably, especially in the clinic, and that might, at the end of the talk, you'll see that might actually have some consequences here. But physical activity is defined as any bodily movement produced by the skeletal muscles to increase energy expenditure above the resting level, whereas exercise is a subset of physical activity that is planned, structured, and repetitive, and we do it in order to maintain or increase physical fitness or health, for that matter. So this is what we when we need to think about what type of activities we want to subdivide this concept into fractions here, and when we look at physical activity, it can be performed at different intensities. For instance, at percentage of maximum work capacity, or how much weight you move around when you do resistance training, the frequency, how often do you do it, and the duration. And the volume of that is the product of these three. So if we look at the time and frequency components of exercise, aerobic exercise that is, Then we have this meta-analysis here from Daniel and Pierre from back in 2013. So on the y-axis, we have the effect of the intervention on HbA1c, and on the y-axis, we have the minutes per week they exercise. And they have some small triangles. The larger the triangles, the larger the weight you have on of the study in this meta-analysis. But what you see here, there's absolutely no association between increasing the minutes, for instance, from 60 minutes a week to 150 minutes a week. And that's interesting because that's kind of like generally thought that you want to increase the volume, yes, but what we have evidence to support is, again, we have HbA1c, is to increase the exercise frequency over the week. So the more times per week you exercise, there's a nice and inverse association with the effect on HbA1c. If we then look at the intensity component of physical activity here, we have a study from my colleague Christian Karstoff, where he investigated this question in a study a while back in overweight and obese type 2 diabetic patients. So the patients were randomized into a control group, a continuous walking group, and an interval walking group. They performed exercise 60 minutes per week, 60 minutes per session, 5 times per week over 4 months. And importantly, the active intervention, so the continuous and interval training, was energy masked. So here is a screenshot of a session of interval walking training where you have the intensities of the exercise on the y-axis and the session time on the x-axis. So here the mean energy expenditures is 71% of maximum energy expenditure with a very high intensity, so almost 90% of peak work capacity. On the other hand, in the continuous walking group, you still had a mean energy expenditure comparable to the interval training, but less or no fluctuations in the intensity here. So interestingly, the effect on work capacity, so VO2 max it's called, was mainly on, almost only on the interval training, where it did see no effects, where the interval training is the black bar and white bar is the control, and in the middle is the continuous walking group. You didn't see any effect on either of the other groups. Looking at visible fat mass, so that's kind of driving a lot of the physiology in vascular complications here, is that you see a robust effect on interval training, but not especially on the continuous training. And going to glycemia, here's the maximum glucose. You saw an effect of interval training, but not the two others, and that was the same for mean glucose as well. And that's again well documented actually in the literature, where we have this old meta-analysis from Norman Bullet from Canada, where you have the effects of an exercise intervention on HbA1c, and you have the intensity of each study. So the black dots are studies. You see a nice and inverse association there. So intensity seems to be really, really important. Increasing that, you'll see a better effect of the exercise component here. And also, what type of activity here? There are a lot of studies out there using either resistance training or aerobic training, and actually the best study and the most cited study here is performed by Timothy Church a while back, where they compared resistance training, aerobic training with a combination of the two. So the patients were randomized either to a control group where they did stretching and relaxing, and that was compared to resistance training over 9 months, aerobic training, or a combination of the two. And the authors, the study group, tried to energy match the 3 groups. So it was the modality per se they were looking for here. And going to the results of that, again with HbA1c on the y-axis and the study month on the x-axis here, we saw no effects. They saw no effects on the control group, and that's, well, not surprising. But they didn't really see any effects on resistance training. A little more effect on aerobic training, but none of these modalities, when they were performed in single, had any effect on HbA1c. But the combination of the two of them had a significant effect here. So they don't really know what the mechanisms are here, but what was observed in the combination therapy was that that was the only that they were able to preserve lean mass. So in essence, the organ receiving all the excess glucose in the circulation, and that wasn't seen by aerobic training alone. They actually lost lean mass there. And also, that was the only group that actually both decreased fat mass and abdominal fat mass. So there is a fat component here that might explain why this combination is more efficient. But there are a lot of studies out there, a lot of meta-analysis, and that's some of the meta-analysis here. There have been performed more than 100 randomized clinical trials since 1984 on supervised exercise and glycemic control. And what we learned from that is, well, with exercise, you can reduce HbA1c by between 4 to 10 millimolars per mole. We have a small effect on blood pressure and a small effect on LDL cholesterol. And it's evident that due to the exercise and that we look at the muscle, and that's also where we have most of the research. We have more research coming up on the liver and adipose tissue now on the effect of exercise, but most mechanisms are known about the muscle. I'm not going to go into detail about that, but just summarize it and I refer you to this excellent review here. But what is evident is when you have an insulin sensitive person and you go from trained to untrained to trained, you increase insulin stimulated muscle glucose uptake. And that's the same for insulin resistant persons such as type 2 diabetic persons. And that's due to an increase in delivery, transport, and metabolism on the muscle level. And also in terms of temporality, that kind of explains why it works. You have one bout of exercise, the acute effects, where you, for instance, will increase energy expenditure, increase glycolysis. Following that, the couple of days after, you'll see an increase in insulin-stimulated glucose uptake. And repeating every training bout like this will increase, for instance, capitalization, mitochondrial capacity, and so on. And that will over time increase basal insulin sensitivity, among other things. And if you increase intensity or frequency or combine modalities, that would shift that response curve upwards and make this treatment modality more efficient. Going back to the clinical side of it, because exercise is rarely performed or delivered in a clinical setting without thinking about other treatments, because we do multifactorial treatment in type 2 diabetes. In essence, we have diet replacement, we have diet intervention, we have pharmacotherapy. So we need to look at exercise in conjunction with those therapies. And that's what we did in a study we did called the U-turn study, where we randomized type 2 diabetic patients into either to standard care plus an intensive exercise-based lifestyle intervention or a standard care group. So we used something called blinded target-driven therapy because we were interested in looking at the interaction with the way we delivered the pharmacotherapy. So every third month, the patients went in to take a blood sample that was analyzed. The study nurse delivered the results to a blinded endocrinologist who would either increase medications if they didn't meet the treatment target or decrease the medications if they consistently met the treatment target based on an a priori algorithm. So in the intensive lifestyle group, they exercised a lot, 6 times 60 minutes per week, supervised in the beginning, and we gradually subtracted the supervision. And during the first 4 months, we did a 25% caloric restriction to induce a weight loss. As Jens said, that is very important in order to have successful management. So at the end of the study at 12 months, we then saw that 3 out of 4 patients reduced the need for glucose-lowering medications, and that's an equivalent to a numbers needed to treat of 3. That meaning that we reduce medications in 1 patient for every 3 patients we do treat with this modality. And interestingly, we used a remission criteria similar to the direct. So if they could get off medications, glucose-lowering medications, if the A1C was below 48 millimolars per liter per mole, and that was obtained in more than half the patients. And we also looked at the dose-response relationship between the exercise component in our study and the chance of remission, again, similar to the direct definition. And the good news here is that going from no exercise to around the guidelines, that actually drove the most of the remission, and we saw a nice dose response relationship here. So exercise would facilitate remission as well. But looking at the interaction, and this is an example from my colleague Nana Pielmark, where they looked at regular exercise and interaction with metformin, which is the first-line pharmacotherapy they'll use in type 2 diabetic patients, where they invited the pre-diabetics and type 2 diabetic patients into the study. The first 3 weeks, they were randomized either to placebo or a metformin, and as expected, metformin reduced the postprandial glucose. The following 12 weeks, both groups performed an exercise intervention 4 sessions a week with moderate to high intensity. And as expected, on the lower up here, the placebo plus exercise actually reduced postprandial glucose. But interestingly, we didn't see any extra effect of adding exercise to metformin treatment in this group. So whether that is a physiological interaction or we met a ceiling effect, I don't know. Nana Pielmark is investigating those more physiological data right now to see what's going on there. But my point here is that when looking at exercise in a clinical setting, we really need to be aware of the concomitant pharmacotherapy, because they will interact in one way or the other. And if you're interested to look more into this subject, I can recommend this review article by Ried from Swansea. So finally, in terms of looking at what is a successful exercise-based management program here, it's of course important that we have a therapist or clinician that knows what they're doing. They have an experience with the target group. We have the evidence to support what we're doing. And what I've been talking about so far is the efficiency of exercise, but I haven't really addressed the management objective yet. So just to remind me, the two most important ones here is to reduce mortality, excess mortality, and reduce the macrovascular outcomes. So for exercise, we don't have any experimental trials supporting an effect of exercise on hard endpoints here. So we have to rely on observational studies. And just recently, an author group here summarized the observational studies on physical activity and all-cause mortality in this dose-response meta-analysis. Here we have the summary HR, which is a hazard rate, so the risk of all-cause mortality for patients with type 2 diabetics on the y-axis, and the total volume of physical activity on the x-axis. And what we see here with this line is that there is an almost linear dose-response relationship, inverse dose-response relationship, meaning that if you increase volume, that could be intensity, that could be duration, that could be time. We don't know in this study. You'll see a reduction in the risk of all-cause mortality during follow-up. So here we have the guidelines around 150 minutes of moderate to vigorous physical activity per week. That would be associated with between 10 and 20% risk reduction, assuming you have a person going from no exercise to doing 150 minutes per week, if they can maintain it. And that's also equivalent to 3 to 4 hours of brisk walking or 5 to 7 hours of housework, with the equivalent intensity in these activities. So that's all good, but we're forgetting the most important person here, the patient, the ones who actually is supposed to do all the work, receive the treatment, and be adherent to any given treatment. So we need to consider feasibility here. Will they be able to do it? Are they willing to do it? What are their resources and what are the preferences? Because if they don't have the resources, or we prescribe something they don't have a preference for, there would be no chance that they would be successful in implementing an exercise or physical activity-based intervention. So there are some studies who have investigated the preferences for physical activity among persons with type 2 diabetes. And what I think is really evident here is that the preferred activities here they are physical activities that would not be categorized as exercise. Just bear in mind that the 100 randomized controlled trials we have here is actually exercise based, so with an aim to increase fitness, so fitness activities per se, but they're not preferred. They prefer walking, they prefer house activities such as gardening, maybe bicycling, and that's really constant across the studies about preferences for exercise. So we might have to look at what preferences they have, or do we have any evidence to support that will actually help them to decrease complications or decrease or meet treatment targets. So for instance, walking and cycling, and then there are some studies out there. So this study was conducted in Europe back in the end of the last decade, and they investigated the association between the risk of cardiovascular mortality and walking. So here we have the hazard ratio, so the risk of cardiovascular disease on the y-axis, and the quartiles of walking volume, so how much they walk per week. And the reference group here is the ones who walk less than 2 hours a week. So assuming that this is causal, that if you go from 2 to almost 4 hours of walking per week, that would be associated with a decreased risk of 60% of cardiovascular disease for persons with diabetes. And that's almost the same effect size going to 7 or more than 9 hours per week, although there seems to be an attenuation of the effect going to higher volumes. Why there seems to be an attenuation here is unclear, but there is a lot of evidence pointing towards the intensity component, that the more you walk, the slower you walk, the lower the pace you have. And if you lower the pace, you wouldn't get the benefit from the intensity, and thus that kind of walking wouldn't be as efficient if you would have walked less with a higher intensity. And also cycling, and we're doing a study on that now. So what we investigated here was whether or not persons with diabetes who change cycling status, in essence, if they stop cycling or started cycling or were cycling all along, how would that affect your risk of all-cause mortality or cardiovascular mortality? In this part of the analysis here, we have the hazard ratio on the y-axis and the categories of the bicycling status on the x-axis here. And the reference group up here are the ones who don't partake in any cycling at all, either at baseline or the follow-up afterwards. So going to the ones who reported any bicycling when they entered the study, and didn't report any bicycling at the follow-up, that was associated with a decreased risk of around 10% of all-cause mortality when compared to the ones who didn't cycle, but that wasn't significantly different from the non-cyclists. Interestingly, going from no cycling to any cycling here, or the continuous cyclist here, that was associated with an almost 40% decreased risk of all-cause mortality during follow-up as compared to the ones who didn't do any cycling at all. And here is the association between cardiovascular mortality and cycling, and the pattern is more or less the same as for all-cause mortality, but maybe even more pronounced, again with the hazard ratio on the y-axis and categories of cycling on the x-axis. But interestingly here, the ones who stopped bicycling, they had no signal of effect whatsoever, so it seems that they didn't benefit from prior bicycling, just making it clear that in order to gain the benefits from cycling, you need to be able to continue to do it here. And interestingly, also the ones who start bicycling and the ones who continue bicycling, well, they were robust risk reductions up towards 50% as compared to the ones who didn't do any cycling here. So just in summary, so we know that exercise improves glycemic control in persons with type 2 diabetes. That is really, really evident, and especially supervised exercise as long as they do it. If you want to make it more efficient, you want to increase the intensity, increase the frequency, and combine different modalities. Also, exercise may help facilitate achievement of the clinical treatment targets, especially for the glycemic treatment targets here. And also, on that note, it's important when you do studies on exercise or diet for that sake, we need to really get a good grip about the pharmacotherapy going on the side here to really understand what's going on. And finally, and I think that maybe that's the most important point, because I talk to a lot of my clinical colleagues about that, we might not want to focus on exercise because that might provide associations to a fitness center or Lycra or whatever it is. But there is actually evidence to support the non-exercise physical activities that can be incorporated in a day-to-day living by either commuting or doing walking with friends or whatever. That actually evidence to support that this is really, really efficient in terms to avoid the complications associated with type 2 diabetes. So that's it for me, and I'm happy to take any questions.
Okay, thank you, Mathias. And we'll ask people to write either their names or their questions in the chat for asking Mathias questions. And I can start out while people write their names. Whenever we talk about exercise and diet and lifestyle interventions in type 2 diabetes, someone plays the devil's advocate and bring up the Look Ahead study, where
Yes.
they did all the right things for a really long time, and then it's turned out that the mortality was the same. Can you comment on that, or is it old news?
No, but actually, I'm happy that was brought up, because
Yeah.
you say they do all the right thing, and I actually don't think they did all the right things. The point here is, and that's the same with the diabetes prevention trial, they achieved the weight loss. That is true. And they also did that in the Look Ahead. But what is really evident, if you look into the studies and have a slow read of the studies and the following papers, they don't implement exercise. So for the Look Ahead, to take that one, the 2016 UNIC study, they actually did objectively measure physical activity on almost half the patients and looked at how compliant they were to the prescription over the 4 years they measured. And remember, they had to do 175 minutes of moderate and vigorous physical activity per week. So at 4 years follow-up, less than 20% followed that prescription. More than 80% did not follow that prescription. And if you look at it on a continuous scale, there was less than a 10% increase in physical activity in that group. So yes, they tried to, but they didn't succeed. So that argument about the Look Ahead or the DPP, that doesn't hold up. So we can't from that study say that exercise doesn't work. We can't say it doesn't. We didn't implement it because it was too hard, but we can't say that it doesn't work. So again, there is an implementation thing to it that we need to consider, and we really need to document adherence to be able to really understand what's going on also in these large trials.
Perfect. Then Julie Røsen has a question. If we can unmute
Yeah,
her.
hi Mathias. Thank you for a great talk. I was wondering about Nana's study. I mean, from a clinical perspective, it's going to be very hard to persuade the patients to do the hard exercise that I know Nana did with her participants instead of just taking metformin.
Yes.
And what is it that you're now looking into in terms of, you said it may be something pharmacodynamic or? Yeah.
So with metformin, there are speculations that you have an AMPK activation that might preclude the AMPK activation you see from exercise. So what Nana is looking into, I don't know the results, but I know she's looking into activation of AMPK and also into mitochondrial activity to understand if something is going on the cellular level, so to say. So this is what she's looking into now. But there's a real consideration that for this patient, they are so poorly regulated that we might not be able to reduce glycemia to a lower point if you use exercise or you use pharmacotherapy. You might not want to have them go any lower, but they might not be able to.
Okay. Are there any implications that less exercise than what she did in her study would be enough to achieve the lowering?
Well, 3 times a week, maybe from the U-turn study could, but we didn't really investigate that, and you might be right, but we don't know, because Nana's study is the first study and the only study actually who has investigated the effects of regular exercise on that intake. So
Okay.
bad answer, but we don't have the data to support it.
I'll have to ask Nana. Thank you so much.
You're welcome.
Okay. Then Mathias, Nicole and Mads, or Nicole and Mads is asking, do you have any suggestions how we enhance compliance? Should we give them free pass to the fitness center, or what do you think?
No, I think most patients would never go to a fitness center on their own. And I think to begin with, I think it's really, really important that the physical activity, not exercise per se, but the physical activity is implemented in an everyday living, such as talking to them about how to get from A to B using a bicycle if they have one, or walking. That's one thing. Also, I think it's really, really important that the general practitioners use the rehabilitation offers you have in the municipalities, because that's actually where they can get the education and support to get physically active. But I think it's really important that you talk about how to implement physical activity on a day-to-day living, not sending them to a fitness center, because they might not know what to do there.
Okay, and as a clinician, we have several kind of type 2 diabetes patients. We have the young obese patients with short duration, and we also have the 70-year-olds with neuropathy and retinopathy.
Yeah.
So is it ever too late to start exercising, or should they just all dig in?
Short answer, no. I don't think it is. But I think you would exercise, patients should exercise for different purposes, because if you have the very old, frail patient on insulin complications, you don't want to go into the remission and glycemia discussion, but what you want to work on there is physical function, how to get around on a day-to-day level. So we want to focus on physical, for instance, maximum work capacity. Can you increase the physical capacity, strength training, stuff like that would help them have a physical function on a day-to-day living. So I think that would be a focus there, and put emphasis on exercises and that could support that. For instance, resistance training exercise using rubber bands, because you have to remember that they have a really poor work capacity, meaning that rubber band walking would actually be perceived as vigorous physical activities for this patient group. So I think we need to talk about what is important to the patient when we go there, because we don't want to impose too much strain on them, because they have too much to look into in the treatment as it is.
Okay. Any more questions? Do you know if they're planning any further follow-up on the U-turn study?
Yes, we do. We hopefully we will be able to do a 6-year follow-up in the middle of next year. We are in the planning process of doing that, and we've been in contact with the participants, and it seems that more than 80% of the original participants are willing to come in for a study day. So hopefully we'll be able to do that.
Yeah, that will be interesting. Yeah.